Hello everyone. I am so excited to do this small presentation about this topic in my college. So I almost feel like I'm back to learning in my college. I'm so thankful for our principal, Dr. Purushimpi, and just the alumni panel to give me this opportunity to talk about this. Um, so we're going to talk about. It's a very simple and very basic presentation. It's going to be very it's a very ground level talk that I'm going to do, because there's a lot can be done in vestibular rehabilitation, but I think so let's just stick to the basic, which I feel that's the characteristic of Sancheti College of Physiotherapy, where I feel like you have to know your basics, and then you can take a step up. And that has helped me come to this level. Being in Canada, owning two clinics, one virtual and one brick and mortar clinic, and the patients also appreciating how much knowledgeable we are. And I totally give this credit to the college teaching that we have got so far. So yeah, let's start this topic. You must have heard from a lot of our patients. They tell us they are feeling dizzy. In India, I know the dizziness term is not so commonly used until the time that I was there. But what I remember was people telling us that they feel giddy. Now, what are they trying to say about this giddiness or dizziness? Let's go a little bit more deep into this, and then we'll take our presentation from there. So, why dizziness? Why are we talking about this topic? In the world of vestibular rehabilitation, this is one of the most important symptom that patients are going to come to you with. That's one thing. Second thing, it is one of the number one reasons for physicians visit by the individuals over the age of 65 years. That means a lot of patients are going to the doctors telling them that they are feeling dizzy, giddy, lightheaded, fainting feeling, all these just different types of word. And in the end, the physicians are also confused, like what's going on with my patient. Is it just because of the medication? Are they presenting a symptom which can be something very detrimental to their health, like any cardiovascular problems, right? Any neurological conditions, or multiple sclerosis, that can present with dizziness symptoms, vertigo symptoms. Strokes, that's another thing, that a lot of the stroke will give you the first symptom as dizziness and vertigo. So that is why this word is very important for us to understand, and from patient's perspective, what are they exactly feeling. Now, like I said, that dizziness, it is an umbrella term for a variety of sensation and it can range from people describing it as just a simple, not simple actually, vertigo or spinning, lightheadedness, fainting, heaviness, sense of falling, off balance, fear of falling, and whatever they want to call as, whatever they want to describe it is correct. It is there in the literature. Some patients tell me that they have a woolen-like sensation in their head. They tell me that they are floating, that they are waving, they are swaying, the objects are moving around, the ground is slipping out of their feet. These are other words that they will use. And it's important to respect these words because they are going to give you a direction towards your diagnosis. I just want to make a correction because I recently attended a beautiful training about vestibular rehabilitation. It was very intense, and they talk about that the vertigo has to be considered separate from dizziness. It's a special type of, you can call it dizziness, but vertigo is an independent symptom, wherein people will describe it's an illusion of the movement of the surrounding or the self. So they will get they'll get the sensation that the world is moving around them. Now, what are the causes of dizziness? Now, so I made this presentation for a junior college, for our first to fourth years. That's why I have put it like this. But this is how I like to understand our body systems. You start from head and then you go to till toe, right? Proximal to distal, or caudal to cranial to caudal, So there are a lot of conditions that can give you from the brain. It can give you dizziness as the symptoms from brain conditions like tumors, strokes, multiple sclerosis, Parkinson's also can give you. and etc. Any kind of space occupying lesions, head trauma, injuries, brain injuries, concussion, that can give you the dizziness. Then you come to neck. Most of my orthopedic physical therapists or manual therapists will be very interested in knowing about cervicogenic dizziness, because they might get some patients who complains of neck pain with dizziness, especially post accident. Then ears, that's my domain, that's my zone there. So vestibular conditions can give you dizziness again. Then vision. And in terms of vision, people might describe it as blurriness, not that they can't see, but they will feel that the objects are moving. Okay, that is also called as oscillopsia. We all are aware of the cardiovascular conditions that can give us dizziness. Lots of cardiac pills will give you dizziness, medications. So there comes another thing. So pills or pharmacotherapy, wherein antidepressants, anti-anxiety, anti-seizure medications, and there are n's and numbers of medications that can give you that can give the patients dizziness. And then we come down all the way to the bottom for our feet, wherein these patients will complain mostly of off-balance feeling if they have peripheral neuropathy or any kind of somatosensory deficits. And psychogenic, all these conditions will affect our psychological health. So anxiety can give you dizziness, or vice versa. Dizziness will lead you to anxiety, and then anxiety is going to trigger more dizziness. So it just goes in a vicious cycle there. Now this is a beautiful... Now I don't have the reference for it. I'm trying to find the reference for it, exact reference, but all the causes of dizziness over the age of 60 years of age. So sorry about that. So we're gonna see a big chunk of this dizziness is coming from a condition called as BPPV. Many of you must have heard of this term. Many of you don't. I'm going to talk about a little bit. And BPPV is an inner ear problem. Okay. And you look at here how many, like the percentage of population with this condition is quite high, like it's 32%. Then comes the vestibular ROS. This is 13%. So right here we are seeing 45% of the population coming with dizziness is because of the vestibular problems. There's a little bit right around another vestibular problem is called Meniere's disease. That's around 4%. So we have like around the range of 45 to 48 or up to 50% of the patient complaining of dizziness because of the vestibular problem. This is fear of fall and disused disequilibrium. Our older adults are quite, you must be knowing about it when you work with the older adults. We have some around here with the brain conditions, so basal ganglia problems, migraine, it's another neurological disorder. Then TIA and CVAs, which do come, but it's very little if you see the numbers here. Now, when someone says dizziness, what exactly is happening in their brain? Now, we're going to leave the part which comes from cardiovascular conditions. We all know that postural hypotension, orthostatic hypotension, or POTS, postural orthostatic tachycardia syndrome. All these conditions, they are coming from your heart and autonomic nervous system, and how they can produce the dizzy or fainting like sensation, right? Now we are talking about the dizziness that is coming from your vestibular system. So simply said, there's alteration in the mechanism of maintaining the image focused on retina, and this is the retinal slip. So when the retinal slip happens, your brain gets an error signal. Most often the brain is able to correct that error signal, and then we can keep our image focused. But unfortunately for patients with vestibular problems, they are not able to get that correction or error, then the correction from the brain, that is cerebellum, and then they get the sensation of that the object has moved, because their eyes are not able to fixate on the target, and that can also lead to a sensation of oscillopsia, and this leads to the perception of dizziness. So I generally use this analogy. I'll explain the patient why are they feeling dizzy. So if we turn our head to the right side, our eyes have to move at the same velocity as the head. Now if I have some vestibular problem in one of my ear, my head is going to move, but my eyes are going to lag behind. When my eyes lag behind, the image on the retina does not form correctly, or it has a retinal slip, and then that retinal slip will cause an error signal which cannot be corrected, and then that's when you will feel the dizzy sensation. Now, what are the characteristics of dizziness, what we are looking for? We have to talk about the history taking for the patients with dizziness can last anywhere between 30 to 45 minutes. And I'd give ample amount of time for the patient to talk, because when they talk about their history, how the symptoms have started, what have they done so far and everything, I get a pretty good picture about getting to a diagnosis from there. So 80%, 60 to 80% of the diagnosis can be made just from their history. So we will talk about what makes it worse, better, how long it lasts. This is one of the most important thing that we want to know from our dizzy patient. Does your dizziness last for less than a minute, so 60 seconds? Because that is going to give us a picture of if the patient is suffering from a specific condition called BPPV, or benign paroxysmal positional vertigo. If it's lasting a minute, if it's lasting more than 2 minutes, then we determine as it can go into a TIA or stroke. There are exceptions, so don't take it that as a rule, but there are exceptions to this as well. If it's lasting from 20 minutes to up to an hour, then you can take it to a condition that's called Meniere's disease. If it's lasting for hours and days, then it can go to a condition, it's a chronic condition that's called triple PD. Is it constant or fluctuate? So fluctuate meaning it does it come with specific body position, and then as soon as you come out of the body position, it goes away. Is it worse in the morning, worse at night, in the evening, after work, or some patients will complain that they're just sitting and they're feeling dizzy, not doing anything, so spontaneously feeling dizzy. That's gonna make me think that I'm dealing with something central nervous system problem if they're getting spontaneous dizzy episodes or spontaneous vertigo episodes. And all other activities will affect, are these things affecting their dizziness or not? Now, another important point for us to understand, if we go deeper into the vestibular world, we know that our vestibular organ has very close connection to the hearing system. They are just in one whole chamber. So if something is affecting my hearing, it can affect my vestibular system as well, and vice versa. Like I said, that there's a condition that's called Meniere's disease that affects your vestibular system. The whole of the labyrinth is affected in that. So the patients will complain of hearing changes, fullness, achy, ringing in the ear, or tinnitus. And these little important snippets from the patients are very important for us to come to a diagnosis for these patients. So we have seen that big pie chart, and it said that 45% of the people complaining of dizziness, vestibular impairments, are the cause of that dizziness. So you see a number of a big chunk of these dizzy population is because of the vestibular system. So it's important for us to understand what's going on in the vestibular system that's making them dizzy, because a lot of these vestibular system disorders are treatable, some are fixable. And so the one that is fixable is BPPV. I should have written positional vertigo and not just vertigo. So it's benign paroxysmal positional vertigo, and it's the most common cause of the vertigo in the vestibular system impairment, and approximates from 30 to 50% for people over the age of 60 years. These are the list of number of impairments. Today we are going to talk about the first two because they are the most common one. As you go more deeper into the vestibular rehab, you would have to know all other impairments as well. I think so I mentioned only 7. No, there are more. There are more than this actually. So BPPV, as the name suggests, benign positional paroxysmal vertigo, and it's a mechanical problem. And how that problem happens, we are going to go, I think so I'm going a little bit faster. So these are the list of the system impairments and or disorders, I should say. What are the signs of symptoms? So these are the common signs and symptoms that you will see in these patients. Nystagmus is one of the symptom. Nystagmus is one of the sign. Then the patient will complain of oscillopsia, and we can test it as well, and that is another signs. Balance impairment will be another signs that patient are presenting. to us. And I have a video for you guys to see and see what the nystagmus looks like. I hope it plays. Let's see. Okay. So he's going to open the eyes wide in some time, and then we can see. So if you can see that there's a little twitching of the eye going. Now he's looking at the light actually. And you see that little twitch of the eye going to the right side. So this is called as nystagmus, and it has two phases. So there's a fast phase and there's a slow phase. So if you look at it carefully, the fast phase is more towards the right side, and then the slow phase is towards the left. So as he looks towards the left side, his fast phase is going to increase. And this is a spontaneous nystagmus that he's getting in the room light. Patient is not doing anything, just looking in this camera system. So that's how we also. So now the next step is, after you've done the whole symptom evaluation, history taking, medical history, pharmacological history, everything, then you go about doing the examination. And this is one part of the examination that we do here. What I'm using here is something called as infrared video goggles, which records the patient's eyes, and you can see the patient's eyes in the dark and in the light as well, with fixation. So we call it as with fixation, without fixation, and that's going to give you different findings. You see that increases, the increase in the right nystagmus there. I'm going to pause that and come back to our presentation, which I think so. Let's see. Yeah. So we've discussed about dizziness, what it looks like, and how vestibular system plays a role in that. Now, what is the purpose of vestibular system? So it estimates the body position and motion. It helps us to stabilize our gaze, which I haven't written here, and it also helps in orientation in space and help us to walk upright with the help of vestibulospinal reflex. So it will help us provide the gaze stability with the help of vestibulo-ocular reflex, and walking upright will give us through the vestibulospinal reflex system. There's vestibulocholic reflex as well, that's dependent for the neck movements and proprioception. Now a little bit about the anatomy of the vestibular system. We are looking at in the labyrinth of the inner ear. Excuse me. So in the bony labyrinth, we have 3 semicircular canals and the cochlea. So cochlea is the hearing organ, and it looks like this. So that's our outer ear. This is our ear canal, external auditory canal, tympanic membrane, and the beautiful 3 little bones that we have that transmits the sound waves into the cochlea. And this little squirrely thing here is the cochlea, and then up top here is the semicircular canals with the otolith organs as well. So this whole system is called as the vestibular system or vestibular apparatus, and the whole system is encased in the bony labyrinth, and the blue thing that you're seeing is actually the membranous labyrinth. Now if I take this out and I look at it separately, this is how it's going to look like. So in our vestibular system, we have 3 semicircular canals and we have 2 otolith organs. So the otolith organs are right here. They look like beans. So utricle and saccule are here. They are responsible for the linear movements of the body, and semicircular canal are responsible for the angular acceleration or the rotational movements of our head and body. And they send information to the brain about these head movement and body position, and then the brain or the cerebellum takes the information, does its correction if need be, and if not, then it sends the impulse to the extraocular muscles, and then our eyes move with the head movement. That's the primary goal of our vestibular system. Plus also it sends the information via vestibulospinal reflex to the spinal extensors and muscles, and that helps in giving us the upright posture. Yeah, so same thing. Now what we're going to do is we're going to look into a little bit more cross-section view of the vestibular system. So they have cut it open, and now they're looking inside where the hair cells are located. So these are the hair cells out. We take it out from here. These are the hair cells. Sorry, these are the hair cells for your utricle and saccule, which contains, we call it as macula. And then in the macula, we have this otolytic membrane, which is like a jelly, and on top of the jelly are the otoconia, or the calcium carbonate crystals. And these provide, these otoconia or the crystals provide the heaviness in the membrane. So when we get this linear, that's why it's sensitive to gravity. So we are just walking, the linear movements, our body takes the information, our brain takes the information from these heavy otoconia, because the cells are going to get, hair cells are going to get activated. On the contrary, if you go towards the semicircular canal, so these three ring-like structures, we have three on each side, and they are located like this. So if you put your thumb in your ear canal like that, and if you use your index finger to put it on the outer canthus of the eye, that's where your horizontal canal is sitting. Okay, and they are very tiny, less than a dime shape. Okay, so they are like this on both sides, and they are coplanar in nature. That means they work together. The other one is the anterior canal. So anterior canal sits up like this, and then the posterior canal sits at the back like this. So the anterior canal is also called as superior canal. The lateral canal is also called as the horizontal canal, and the posterior canal is called as the posterior canal. It doesn't have any other name. But if you find in the literature different terms, it's the same. That's what they're talking about. So both the horizontal canals work together. The anterior canal of the left side will work with the posterior canal of the right side. So they work like this. So that's my anterior canal, that's my posterior canal. Okay, and then we go the other way. So same thing, that's my right anterior canal and left posterior canal. So they work together. So they are coplanar in nature. They are approximately 90 degrees to each other, but they are tilted off the plane. So that's another thing that we have to remember about these canals, because that will help us understand how the why do we get the nystagmus in the pattern of what the canals are doing. So yeah, we have cut it open. We cut open the semicircular canal, and then the semicircular canal, we are looking at the ampulla of this semicircular canal, because it's enlarged in one side of the opening of the canal. This enlargement is called as the ampulla. We have the same type of hair cells like we have in the macula. They are a little bit different physiology, but they are the hair cells which are taking the information to the brain. These hair cells, on top of it is again a jelly-like substance that's called cupula, but they do not have the otoconia or calcium carbonate crystal. So the semicircular canals are not sensitive to gravity. And this orange color stuff that you're seeing, that's called as endolymphatic fluid. So it's just a fluid almost similar in consistency like water. So it flows in the canal, and then as it flows, it will deflect the cupula, and with the deflection of the cupula, the hair cells are going to activate. You remember your physiology in the first year, the deflection, the depolarization and repolarization of these hair cells, and then they will send the information to the brain, and then our third, fourth, sixth cranial nerves will activate, cause the oculomotor movements, and we will see what we see with the eye movements. I hope this is good. Let's move to the next part. So we are talking about the three main conditions. Actually I said two, but yeah, we're just going to add a little bit more to cervicogenic dizziness. So BPPV, we discussed about it. Okay, yeah. So in BPPV, what happens is these crystals, they will fall off. So they will fall off from the utricle here, and then they will float down at the back here. So they will float down into the semicircular canal. The most common semicircular canal that it will float down is the posterior semicircular canal, and they will hang in there. Okay. Now what happens with these patients is, whenever these patients change their body position, so for example they are lying on the bed and they will roll onto the bed, roll onto one side, these crystals will float. It's going to deflect your endolymphatic fluid. That's going to deflect the cupula, and the cupula is going to send information to the brain of the deflection, and their eyes will jump. Okay, that jumping of the eyes is basically the nystagmus, what they get. So when you look at the patient, you will see that the eyes are moving, and that's the nystagmus. But what the patient will complain is that the whole room is spinning. Okay, now because the eyes are moving in a specific fashion, so like for the posterior canal, the eyes will torsion and the eyes will go up. Okay, that's because we are stimulating the oculomotor nerve, oculomotor muscles, and they cause the torsion and the upbeating nystagmus in those patients. So our goal as vestibular therapists is to put these otoconia back from where they came from. Okay, so in vestibular rehabilitation, we have techniques that we use to put these crystals back in position. They're called as canalith repositioning maneuvers. They're pretty simple to do. It's just that we need a little bit more cooperation from the patient and our understanding as well, where the crystals are floating. And once we put the crystals back in position, they will stay there, although there is a chance of recurrence in these patients. But at least you can fix it for that time. So our goal for these patients for BPPV is for complete remission. And once the crystals are back in position, these patients will feel better. They will not get any vertigo sensation. They might have some postural instability. So if you find that these patients have postural instability, then you work on a traditional balance rehab with these patients. Okay, the next one is neuritis. So for neuritis, I'm going to take you back right here. So neuritis is basically the inflammation of your eighth cranial nerve, or the vestibulocochlear nerve. The neuritis can happen either because of viral inflammation or bacterial inflammation. It can also happen because of the head injury as well. Not that there is an infection, but it can damage the vestibular nerve as well. So if I like to understand it in a way where, so when the patient gets Bell's palsy, that's the inflammation of the 7th cranial nerve, and the signs and symptoms the patient shows is the 7th cranial nerve affection. So there will be paralysis, there can be some ringing, there can be some tongue sensory deficit, etc. And the management for that is pretty straightforward. Patient goes to the ER, they get the steroid shots, or they get the steroid medications and acyclovir as well, and some antiviral drugs. Unfortunately for the vestibular neuritis, it is not taken care of very well, because the patient comes when complaining of vertigo, dizziness, nausea, and vomiting. Okay. When someone comes with these 4 complaints, the doctors are going to look into controlling their nausea and vomiting. They don't care about the vertigo. They don't care about the dizziness. And in a couple of days, patients does start to feel better. The first couple of days are very, very severe for these patients. It's very violent, and then it will settle down. And then the patient is just, going about taking care of the day, and then they can improve by themselves as well. Some patients do not. Okay. So if there is inflammation of only the vestibular nerve, then it is going to be called as vestibular neuritis. If there is involvement of both vestibulocochlear nerve, that means there is some hearing loss as well, then it is called as labyrinthitis. So if someone goes to the emergency with hearing loss, with dizziness, with imbalance, nausea, vomiting, they are taken care of much more seriously, because the hearing loss component is very important for the patient and very important for the physician and the patient. And then the doctors will prescribe them steroids. They will do a thorough examination, because there are a lot of strokes which can cause hearing loss as well. So they will rule out everything for them. And then once you prescribe the steroid, the inflammation goes down and the nerve starts to recover, the swelling comes down, and then the function starts to come back. Acute phase, I described it already. The subacute phase is the patients will not get vertigo, but they will complain of the dizzy, off balance sensation, and there's something called as oscillopsia, or the blurriness of the vision or inability to focus on a target. That's the primary complaint of the patients with vestibular nerve affection. So you do the examination and you plan them, and a lot of you must be aware of the gaze stabilization exercises. So that's what we prescribe for these patients. They have to be dosed, it has to be customized for the patient. And study done by Susan Herdman, I don't remember the year, but they have done the dosing. And actually, clinical practice guidelines for vestibular rehabilitation has just recently come out in 2021, which has suggested strong recommendation for vestibular rehab for the patients with unilateral vestibular hypofunction or bilateral vestibular hypofunction, either ways. And then you prescribe, you customize, you supervise the exercise program once or twice a week for at least 6 to 8 weeks, and you prescribe them gaze stabilization exercises for at least 3 to 5 times a day, and you have to get to the level of them doing it from minimum 10 minutes to up to 20 minutes, depending upon the conditions. If it's bilateral vestibular hypofunction, they recommend 20 minutes per day. Unilateral, around 10 to 12 minutes per day, depending upon the chronicity of the patient too. And they have shown amazing results. And I have had few patients as well, they've got complete recovery, no problem at all. So we've got pretty good outcome for treating these patients. Now, bilateral vestibular hypofunction, wherein the nerves get affected, both nerves will get affected, and then there's a complete vestibular loss, complete or partial, but it's on the both side. It's caused by generally ototoxicity, so gentamicin toxicity, and that can be very, very that can be very, very hard for these patients because they have lost their balance function, stability, so they cannot be in dark and on uneven surfaces. So standing and walking is very difficult for these patients. They are at high risk of falls, and they have lots of oscillopsia. So gaze stability is very, very poor in these patients, but as per the clinical practice guidelines, strong recommendation for vestibular rehab for these patients, and it has shown good outcome. And the prevention of falls. Okay. Now the last one was cervicogenic dizziness. Now, since we have lots of orthopedic manual therapists, and this is one of the things that it's coming into picture quite a bit when you do vestibular rehab as well. You assess everything is negative for these patients, no problem with crystals, no problem with the vestibular nerve, but still these patients are getting dizzy. So that's when we come to understanding of cervicogenic dizziness. It was also called as cervical vertigo, proprioceptive vertigo, cervicogenic vertigo, and cervical dizziness before. Now they have changed it to cervicogenic dizziness. It's a very good, it's an amazing paper by Riley in 2017, and they have done a beautiful description, assessment, and management of these patients. So they have to have associated neck pain. A lot of my patients will not complain of neck pain, but they'll complain of neck tightness or headaches. So you have to understand where the headaches are coming from. So they will report that they're getting headache right from here, and then it wraps around their eyes like that. So there is cervicogenic headaches as well, and they can have associated dizziness. And it is characterized by the presence of imbalance, unsteadiness, disorientation, neck pain, limited cervical range of motion, may be accompanied by headache, like I said. So what are the possible mechanisms here? So we have faulty cervical proprioceptive inputs as the contributing factor. There's a disruption of normal afferent signals from the upper cervical proprioceptors to the vestibular nucleus, resulting in an inaccurate depiction of head and neck orientation in space. So that's one theory. And we know that upper cervical spine has immense proprioceptors, and then because of the neck pain tightness, the function of the proprioceptors decreases, and that can result in both headaches and dizziness, because these muscles are hypotonic, they're not functioning. A lot of us have bad habit of sitting, bad posture and sitting, always working on computer on that, so the posture, postural dysfunction also doesn't help these poor little muscles. So what are you going to do with these, with the dizziness? Just one more point I wanted to talk about cervicogenic dizziness is there's a lot of assessment that you can do to delineate if it's coming from your C-spine or if it's coming from your vestibular system. And they can be just merged as well. You can have both together. And for cervicogenic dizziness, I really like to do a test that's called joint proprioceptor error testing. I don't have it here. I do have it actually. So if you can see the circles that we have on that chart, I use that as testing with the help of a laser pointer on the patient's head, and I understand if their cervical proprioceptors are firing or not, and they have to do it. So keep the eyes closed, move the head, and bring it back to the same center spot with the laser and see how much they are off. The other thing is a smooth pursuit torsion test. So you turn the head and you check the smooth pursuit and see if that is affected or not. And there's cervical torsion test as well. So if their balance is affected, is their balance affected in the standing position without moving their head, or if they turn their head and the balance is affected. So these are the three things which I generally test for these patients. So what do we do with the dizziness? Like I said, 60% of making an accurate from the intake of the interview. So assessment is obviously, we all know, very important. Medical history, gathering all the information. These patients, they generally take quite a bit of time for assessment and treatment planning. So our session will last anywhere between 1 hour to an hour 15 minutes for the assessment, and sometimes the assessment can go on in the next session too. And then you do some simple bedside clinical test. Neurological exam, if you're suspecting red flags, please go ahead and do your neurological testing. Everything from higher function, speech, reflexes, sensory, tone, all the good stuff that we are so good at. And then add on to the oculomotor exam. There's head thrust test, very clinically significant, this head thrust test. There's dynamic visual acuity, there are BPPV testing, balance testing, very important. You can do modified CAT-SIB, time up and go test. It's going to give you a very good picture of what you are dealing with. And then the vestibular rehab therapy. So it is an evidence-based, pure exercise-based treatment, and it is designed to promote the vestibular adaptation and or substitution. That is what we are looking. We all know the neuroplasticity principles. A brain is very good at reorganizing itself and giving us recovery. So we are using the vestibular adaptation principle, where we are adapting the lost vestibular function. And for substitution is basically the function that we have lost completely. We are using other mechanism to substitute for that. So for example, if I have bilateral vestibular loss, I'm possibly using my smooth pursuit mechanism to compensate for that gaze stability. So it helps restore. So vestibular rehab therapy restores your gaze and your postural stability. It alleviates vertigo, so alleviates BPPV. That's what our goal should be. It helps and improve our aerials, function, and decreasing falls, which we all know it is so important for our older adults, that you don't want them to be falling, because this vicious cycle of falls, over falls, that just keeps on increasing, and then it increases their mortality rate. Once they have a fall, they have fracture, they are bedridden, and they are just gone from there. so you don't want that. The treatment strategies that we do is, the first one is, if the patients have vertigo, then it's canalith repositioning maneuvers we are using. There are n number of maneuvers. There are some more effective than the others, so choose wisely what you're using, and it will depend upon the position of it will depend upon the canals that are affected. So if I have a horizontal canal, BPPV, I am probably not going to do an Apley's maneuver, okay, because it's not going to work for that. So for horizontal canal BPPV, I'm going to use something called as barbecue roll or a 360-degree roll maneuver. Education, big piece. You have to make the patient understand why are they feeling the way they are feeling, why is this dizziness, where is it coming from, and what can we do for it, how long is it going to take to get better, is it ever going to get better? These are the main questions that they have. Making them understand, calming the nervous system helps significantly in these patients, because there's a high degree of anxiety that you'll be dealing with these patients, so very high psychological barriers here. Adaptation exercises, these are the standard gaze stabilization exercises. You must have learned a little bit, and I know there is a chapter in our amazing book O'Sullivan about vestibular rehab, and they talk about gaze stabilization exercises where you put an X on the wall and you shake your head. It sounds pretty simple, but when you actually dose it, it's not very simple. So you have to make sure that your dosing is correct for these patients. They're not overdoing it, they're not underdoing it, all those stuff. Substitution exercises are the imaginary target and gaze, what's the word for it? Gaze fixation, I feel like that's the word for it. Imaginary target and eye fixation. So they will move the target they'll move the eyes to the target first, and then they will move the head. Then the habituation exercises are basically desensitization exercises, wherein the patient, if they have motion sensitivity, then we prescribe them habituation exercises. Balance exercises, gait, our standard balance training protocol. It doesn't change. Whatever you do in neuro rehab or in ortho rehab, sometimes you have to do same stuff. But again, make sure that your patient knows what they're doing, and if you're taking a patient who has bilateral vestibular hypofunction, and if you put them on foam and you ask them to close their eyes, they will definitely have fall, because these patients their vestibular system is not functioning at all. So you're not going to put them directly onto foam and then eyes closed, right? So progression is important for this patient, and probably you may never put them on foam, right? Treatment strategies. Okay, so further gait re-education. A lot of these patients are walking tilted because that's where their world is. So giving them feedback, correcting them. They're walking very stiff, no body rotation, no head movement. Okay, so trunk rotation is very poor for them. So working on that, trunk mobility, neck movement, and if the need be, they will need assistive devices. So for bilateral vestibular hypofunction patient, they will probably be dependent on walker. So training them with that, giving them walking poles if need be. So our different gait training strategies. Visual vestibular integration exercises. In the end, you have to integrate these two systems. In fact, all the three systems, so visual, vestibular, and somatosensory system integration exercises. Physical conditioning, very important for these patients, because these patients are almost bedridden. They don't want to go out. They are socially isolated. They know if they move around, they're going to get dizzy, so they will avoid every possible movements. But that affects our vestibular system, and this will lead to a vicious cycle. So vestibular system is not getting input because they are not moving, and then there is this disuse, atrophy. I want to say atrophy, but use it or lose it. So they're not using their vestibular system well enough, and then it loses further. Vision exercises. Not for all the patients. This is very, very specific to concussion group or traumatic brain injury group. We don't do just vision exercises for our vestibular only patient. Okay, so if someone has BPPV, I'm not going to give them smooth pursuit or saccadic exercises. For vestibular hypofunction, I'm not going to give smooth pursuit and saccadic exercises again, because that's not the problem is. But for a patient with concussion, they have problems with eye tracking, they have problems with saccadic eye movements, they have problems with conversion. So I'm going to give to these patients. So make sure you're choosing your exercise appropriately. Clinical practice guideline has strictly said about no oculomotor exercises for the patients with vestibular dysfunction. Cervical repositioning training for your cervicogenic dizziness patient. I do sometimes add on this to my patients with just pure vestibular problems. Because of the neck stiffness, because they are protecting or guarding their neck, they will have neck tightness. They're not using their cervical deep neck flexors, so I will activate that, and I will also ask them to repositioning, so I will do that as well. And surface orientation is basically a grounding technique that we use to help calm down the nervous system. Their autonomic nervous system is on fire. They have very high anxiety. They have fear avoidance behavior pattern. So we have to break this pattern. And if need be, that if you're not able to handle these patients' psychological component, refer to psychologist. So the key to success, we all know about this, so I'm not going to repeat it. For every physiotherapy or diagnosis that we do, this is what we need: timely diagnosis, awareness and education, customize the treatment plan. It is very, very important for these patients. Do not give generic exercises. A lot of these patients will find exercises on YouTube or internet, and they will do that, and they will not find the recovery. Some do recover because there is spontaneous recovery as well in these patients, but not every patient recovers like that. So it's very, very important that you customize your exercise plan for these patients, and an appropriate referral if needed. We are seeing a lot of patients, especially in Canadian healthcare system, because you don't get to see the ENTs soon enough, or neurologist or neurotologist soon enough. So these patients are struggling, so they come directly to us. They will find us online, and at that time we suspect that they have Meniere's disease, or we suspect that they have perilymphatic fistula. These are some of the conditions that vestibular rehab is very, very limited or not done until a medical management is taken care of. Vestibular migraines, these are other things. Acoustic neuroma. Patient comes to you, you diagnose them, and you have to refer these patients. Do not keep treating these patients. You're not going to make any progress with them, or you're going to make the condition worse. So if in doubt, refer. Indian healthcare system is much better in that regard. Probably you won't get these patients because they will directly go to see an ENT or a neurologist, and the investigation is pretty solid in India. You can just go and do your MRI by yourself. You don't even need a prescription for that, right? And you'll be diagnosed right away. So these difficult conditions are very well diagnosed in India, but unfortunately not managed very well. And we have other way around. It takes a lot of time to diagnose. We struggle for the referrals. Patients don't get referral for 6 months to a year because of the wait time. But the management is pretty okay. So as vestibular therapists, we are taking sort of in charge of picking these difficult patients and streamlining them faster. So if we write a referral note to the GP or general physician, and they will speed up the referral process. That's about it. These are my references. It was amazing doing this presentation for my alma mater. I feel so connected with all of you. I hope to be doing a little bit more teaching in the future. I may be organizing some vestibular courses in India, so wait for it. And if you guys are interested, then please join the course. I would like to extend a special thank to my mentor Bernard Bongs for spiking my interest in this. And I would also like to thank Dr. Dhara Kapoor. She has been helping me quite a bit about picking up the research paper, how you should read the paper, what you should take from it. So thank you so much, ma'am. And thank you, Sona ma'am, for organizing this alumni talks. It's a great initiative, and all the students who are helping her. And yeah, thank you guys.